Norm, who is our technician since 20 years and has put down the catheter more times than he can count, I'm sure. So thank you very much.
Thank you, Jennifer. Any question from the audience? Thank you, Jennifer. Any question? I think I would like to ask the audience a question, and I think that's the question, and we have a few microphones, don't we? And that is, how comfortable do you find yourself with the diaphragm electrical activity? How much do you actually know about this signal? Anybody want to comment as a clinician? I mean, diaphragm EMG has been around for years and years and years. We've done power spectrum analysis. We looked upon its amplitude. But it really isn't a very, very covered field. There are no textbooks around anymore that kind of gives this. We are rewriting them kind of today. But is this something that makes you feel kind of like it's a bit of a unknown territory?
Yes.
Yes. Yeah. Should I trust that?
Excellent opportunity.
Do we have a microphone? Sorry. I think since we're here, it's like important to have a discussion and don't be quiet. I mean, it's not,
Hello.
no, it's not bad.
But it's also an excellent opportunity for us,
Yeah.
because now I believe we have the opportunity to actually see breathing and be able to interpret a lot more. I do have one question, because I work with NAVA frequently. My name is Bernard Fowler, and I work with McKay, okay, and I'm from McKay Middle East. I do have one question, because I have had several patients on NAVA in the adult patient population, where it was pretty obvious that the patient was weak over time when we put the patient on NAVA. As the patient grew weaker, we had the diaphragmatic EMG decreasing, which is completely opposite to what we saw in the slide there. So do you have any information or any observations relative to that?
You want to answer?
No, you can answer.
It depends where the weakness is coming from. If it's from the contractile machinery and the patient is able to increase the respiratory drive to compensate for it, I believe in most cases they will. There have been, and you maybe, Leo, want to talk a little bit about the neuromuscular aspect, because I don't know very much about that. But then the whole issue of central fatigue versus the muscular fatigue, peripheral fatigue comes into play. Are you keeping everything else is the same, the sedation level and everything, it's just that the EDI is dropping over time? And are they able to ventilate themselves with that EDI, or are they not?
Yeah, that's the big unknown.
Okay.
Hey, Guillaume, yeah? I have another microphone
Can
here.
you comment a bit on the level of awakening? Because in clinical practice, we observed very frequently that the level of EDI change a lot depending on the level, not even without any medication interference, but just because the baby is awakening or is very sleepy, the EDI can double or triple. And I'm not sure that is always related with an increase in the ventilatory drive. Could you comment on that?
So you're talking about sleep studies and EDI?
Yeah.
Yeah, there have not been any done yet. When I'm at the bedside and I see a premature baby, it's clearly that they are sleeping, that the EDI is lower when they're asleep, but not a formal characterization. Where's Lisa? Lisa Latonen, where are you? Do you want to comment on the sleep and the, I know that you are big on sleep in babies and breathing patterns, so do you have a comment, or?
I don't have that data.
Okay.
And, yeah.
Okay.
We would like to have a formal sleep study
Right.
to get the feel of EDI signal related to sleep in preterm infants. We have a clinical experience that the signal goes down when the baby is sleeping well. And that I would love to have that confirmed with science.
We have a experience from University of Virginia who studied 52 patients and found that 20% of their patients, when they are on assisted modes, or in few cases also on volume control, actually do not breathe. They are electrically silent. That is like putting somebody into the cardiac ICU and turning off the heart for no reason, not even knowing. I think that is something that I think we call for, because this signal comes straight out of the brain. It translates into its electricity of the diaphragm, but I mean, if the connection to the diaphragm is there and intact, you should see an electrical activity of that muscle. And if it's not there, because you either sedate too much or because you ventilate with too high volumes or too high frequency. Mister?
It's the paper.
Can we have a microphone, please?
A paper which is still impressed from Pedro de Oliva in Madrid made a study on comparing pressure support and NAVA. And what I think one of the interesting interpretations in the paper is that they measured the comfort score, and he implied that the patient is the sedation level in the baby during NAVA is increased, because the comfort score goes down, and indicating that the sedation level is increased, because there are less disturbances, which is quite an interesting
There's a comment
observation.
just behind you there. Mister? I think you have a comment.
Take your microphone and makes your life easier. Jennifer, thank you very much for this presentation. And I have a question regarding the neonatal EDI. You've shown that the EDI peak is around 10.8, and based on 24 infants, based on 24 records, it's not very convincing. And do you feel comfortable that that's the EDI peak that can cover the whole preterm and term neonatal population? And is there any relationship between the gestational age and EDI signal?
So, yeah, and that was an average of the 28 babies of published data with babies who are on some kind of NAVA, because there's so many things that can affect your EDI signal. It's a mix of pediatric ICU, so up to 18 years old is included in that 10.8 microvolts thing. It's a very misleading number, but I wanted to put it up there so that people know that if you see 95 microvolts in a baby, that's probably too high, and 1 is probably too low. I wanted to give a little bit of even though it was a specific number, I want to give a little bit of an idea to people what to expect. I know that Howard Stein in Toledo has started to look at EDI peak and EDI min with gestational age. So he's doing a daily monitoring type of study. But again, some of his kids are ventilated, some of them are on CPAP, some of them are on nothing at the end of their study. So it's very hard to compare because there's so many things that can affect it. I don't know, when you're at the bedside and you're using it, don't you see them all around between 5 and 15? I mean, that's what I saw in Finland, and that's what I saw with you guys in Poland. And
well, sometimes we see very low, and sometimes we see very high, and it
what's
also
very high, though?
Well, very high is even 40.
Okay.
And that sometimes it's not correlating with the severity of respiratory distress. That's why I've asked that maybe there are some patients, maybe more term or near term, and they sometimes have a high EDI signals without severe respiratory distress.
Yeah, so Guillaume, do you want to answer that? Because we just published a study in the pediatric population on NAVA, pressure control, pressure support, and the mean EDI was 9 microvolts there. And these are kids about to be extubated, so not so sick, and on NAVA on a comfortable level. So, and these were all, I don't know, 3-4-month-old babies.
Yeah, and I'm presently conducting a study in pediatrics, so not in neonatal ICU, but in pediatric patient, and when they are on normally breathing, just before they leave the ICU, and the median value is rather higher than what you have shown, is around 15. And some of the patients are not really normal, they're just leaving the ICU, so they're not very sick. But the range is rather large also. The standard deviation is around 10, I think, so I'll present the data tomorrow. But I think that I agree with you. Sometimes the patient have a very high activity, around 30, and he has no respiratory distress. But in most of the case, there is a problem. If you are higher than 30, 40, we have to look at the baby and to wonder why they have so high activity.
Yeah. I think we have to go on to the next presentation. I think this issue will come back on the roundtable discussion later, because I think there are more comments in the room about the EDI. So let's move on with the next presentation, which I introduced myself for.
Hi, Glenn.